Para terminar este bloque de este simposio, pues llamamos de nuevo a nuestro gran amigo, el doctor Dushyantha Jayaweera, recordemos que mejor conocido como el doctor Jay, quien básicamente, después de obtener su posgrado en infectología en el Reino Unido, ha pasado el resto de su carrera como profesor de la Universidad de Miami en el Jackson Memorial Hospital y trabajando básicamente y exclusivamente en VIH, exceptuando estos últimos 2 años en donde todos tuvimos que cambiar nuestro libreto y ser traidores al virus tal como lo mencionó Carlos. Traicionamos el virus que nos dio de mucho conocimiento y de mucha discusión durante tantos años por otro virus poco agradecido. Así que de nuevo llamamos al doctor Jay para que nos hable de un tema bastante importante que requiere un tratamiento muy serio, como es controversias en aumento de peso con terapia antirretroviral. ¿Serán estos hechos o es exageración? Jay, thank you very much again.
Thank you. Thank you, Ernesto. Thank you, the Congress, for inviting me. And I guess you have heard a lot about antiretrovirals, and there was a lot of conversation about weight gain. I think there's not much controversy about this. It is pretty obvious, but it's important as practicing physicians. It's one thing to have theory, but the other thing is to practice. So it's really important that what you hear today from everybody, including me, and then when you go back to your clinics, that you have to practice what we preach. So with that, I'll get started. So in my outline, I would be talking about obesity in animal studies. There have been multiple animal studies been done. I just picked one example. Obesity and HIV in chronic immune activation, because we know in HIV the biggest problem is the chronic immune activation. So obesity contributes towards this immune activation. So there are unintended consequences of obesity in everything else, which people do not realize that weight gain is not just a simple thing. The consequences of excess adiposity we will discuss. The role of antiretrovirals, which will be the main theme to the end. And finally, the potential interventions. There are multiple interventions that you could do, and the prevention is, I think, is the best way to go about. So if you look at the mouse study, these are humanized mice, and these are the people on standard diet. And if you put a mouse on a standard diet and give the regular chow, there's not much weight gain. But if you take the same mice, similar, I mean, it's not the same mice, but similar mice, and then if you give the high-fat diet, suddenly the mice on antiretrovirals have a higher weight gain than the mice on the standard diet. The same thing in the fat mass. And you can see the Homer insulin resistance also seems to be affected in the mice who are on a high-fat diet. So that gives you an idea. And of course, the gene expression also is increased in the people who are mice on high-fat diet. So it gives you kind of an idea that there is something real about antiretroviral therapy, that I'm not suggesting any antiretroviral at this moment, but towards the end of the talk, you'll realize things start separating off, which shows the integrases and some of the NRTIs are contributing to this. But it just shows that there is a biological phenomenon happening here with obesity, which leads to weight gain, and especially in high-fat diet. Now, this is really important to understand, because when I write a prescription for antiretrovirals, this is the first thing I talk about, because it's really important. I mean, you'll get, as I go on, you'll realize what I'm trying to say, especially in women, that if I'm talking to somebody, I would say, there are two options. Either you can go with the best drug that is approved with the most potent, or you can get the lesser one, which will not give you weight gain. Now you make the choice. So this is again looking at the effects of the diet-induced weight gain, and you can see that weight gain alters the insulin sensitivity, which I already shown in mice experiment, and also this gene expression, then the increased recruitment of macrophages to adipocytes. What you really have to realize is that the fat is not just a dead organ. It is something that is active and that it can be attracting a lot of other immune activation cells, macrophages and other lymphocytes, which could be affected by you're not taking care of yourself. And of course, increased expression of inflammatory cytokines. Now, this was an ACTG study looking at 328 antiretroviral naive patients, and different regimens. One was atazanavir, the other one was darunavir and raltegravir, and basically 90% were male, 10% female. So that kind of defeats the objective of the study, but at least this validates some of the things that we are trying to say. And you can see that the weight gain was quite significant between the baseline and at the end of the study, which was week 96. And it didn't matter which arm you were putting, but everybody gained weight. Now, we all know that in some countries, HIV is a wasting disease, so there is the catch-up weight gain, but we are not talking about that. We are talking about significant weight gain. So if you look at obesity in people with HIV, there are fundamental things that drives this. One is the antiretroviral therapy. The other thing is the obesogenic environment, which is like eating too much, and because when you start taking some of these drugs, your appetite increases, and some drugs sort of lowers the appetite, like tenofovir has the advantage of kind of lowering the appetite a little bit. So that's why that you see that when you're on tenofovir, your weight gain is not that significant. And then shift in demographics and the aging population as we get age. I mean, we all know that when you get older, that when you eat and you put on weight, when you're young, you eat like crazy and you don't put on weight. So it's normal. And diabetes mellitus is the consequence of weight gain, neurocognitive impairment, hepatic disease. I will talk about non-alcoholic fatty liver disease, which is associated with weight gain. We see it quite often. And also the cardiac metabolic problems, the normal ejection fraction cardiac failure is higher with obesity, So these are things that the ordinary patient who is seated in front of you does not realize, which you should disclose before you write a prescription. It's easy to write the easy prescription, Biktarvy or dolutegravir, whatever, with the drug of the choice. But it's much more difficult to go into details and say, if you take this, this could happen. If you take this, this could happen. If you control your diet, you could mitigate some of these things. And you can actually guide the patient in a joint decision in how you treat. So this I just put to give you an idea that it's not just weight gain. There's some areas there is malnutrition in Africa and some parts of sub-Saharan Africa, and the effects of those are given here. For example, on the obesity side, they are the high circulating IL-6 and the leptin, increase in leptin, which is directly proportionate to the circumference of your abdomen, and then this leads to increasing cytokines, which are pro-inflammatory. And you can see the innate and adaptive immunities are affected by obesity and the potential interventions. I'm going to skip that because I'm going to get to that later. So these are these things that you have to, what I was mentioning about the gene expression. There is a connection between certain adipose tissue deposits, like visceral adipose tissue and skeletal adipose tissue and different areas. And those things are directly have an effect on gene expression, even the things like the HDL levels, the LDL levels. So it is all interconnected, and that these have to be taken into consideration. So I also already mentioned that inflammation is the thing that drives HIV, and all the T-cell apoptosis, everything happens because of the inflammation. This is proven like 20 years ago by the National Institute of Health. But I want to focus on the bottom of the yellow area where the pro-inflammatory, this bit where fat alterations leads with the lipid release and metabolic defects leads to immune activation. So again, you have to, if you explain to the patient, and I'm just trying to correlate this into more translational and implementation science, where if you tell the people, I mean, they will make an informed decision that if you keep your weight down, that you're going to be really healthy. So we have seen this about 100 times over the last 2 days, so you know what is approved currently. So these are the drivers of weight gain. So some people who are malnourished, when you start on antiretrovirals, they will gain weight because they're catching up weight. But on the other hand, there are clearly evidence that there is dolutegravir, bictegravir, and tenofovir, the TAF, are real drivers. There is no argument about it. There's data. I can show ton of data which clearly shows that these are validated drugs. And of course, protease inhibitors. So you could ask, so what do you do? I mean, these are the best drugs you have. I mean, what do you do? Well, there are things that you can do. There are things that you can do. So tenofovir has a negative effect because it suppresses your appetite a little bit. Efavirenz is good, but efavirenz may not be the best drug to be used because there are other adverse events which are associated with efavirenz and its resistant issues my previous speaker spoke about. And of course, the other thing is women are actually at a higher risk of gaining weight, and of course, the blacks and the Hispanics, which, of course, you guys deal with it every day. So what actually happens when you start on antiretrovirals? As you start on initiated antiretrovirals, from a position of starting antiretrovirals to stable antiretrovirals, there is this one thing is that reduce resting energy requirements and your improvement appetite, which I mentioned, and increase energy, so you feel good, and then of course, yes, you can see that access to nutrition and smoking cessation, those things that we provide when you are primary care, and then of course the antiretroviral regimen that we use. So what I'm trying to emphasize is that when you are starting antiretrovirals, it is so important to monitor these things like the weight and the abdominal girth. It's really important, the way measuring the abdominal girth, because this is directly proportional to things like non-alcoholic fatty liver disease and cardiometabolic problems. So as you see that the belly is getting bigger, now you have to say, come on guys, you got to do something about this. Especially this has been shown among the South Indians. In South Indians, they tend to put on belly fat more than the rest of the body, and that has been considered a marker for liver disease and cardiovascular disease. As you can see on the other side, the consequences of this is the visceral fat gain, hepatic steatosis, an epicardial fat increase, and the muscle effects. So the comorbid conditions that develop along with that, as you can see, the insulin resistance, which have been spoken before and I just mentioned, and increase in triglycerides, mixed hyperlipidemias, liver fibrosis, which causes non-alcoholic fatty liver disease. As we control hepatitis C, hepatitis B, this would be the main cause of liver cancer. So it is not that simple. It is not that simple. The non-alcoholic fatty liver disease is driving towards as a potential cause for liver cancer. So hypertension, coronary artery disease, peripheral vascular disease, sarcopenia and frailty, and of course neurocognitive decline. So all these could come, that of course come with, in addition, aging. So let's look at some of the studies that were shown. I'm sure these studies have been shown many times by others. It's studies 1489, 1490. We were part of the study team from Miami. So this was bictegravir versus dolutegravir on initial ART regimen, and going through to up to 144 weeks. That's another thing. The weight gain, so some companies, because they want to show that their drugs are better than other people's drugs, they may cut the data at say 48 weeks or 96 weeks. I think it is always good to look at long-term data, so then you know the real picture, what's going to happen with the antiretrovirals. So, and if you look at the data, it is very clear that the weight change in women seems to be a little higher than men. And you can see that week 144 is much higher than week 48. and dolutegravir with TAF and TAF and arm, dolutegravir TAF arm seems to do much worse than the other arms. So, so basically, this is establishing that the weight gain is much more among the women and much more among the dolutegravir, and if you are combining with TAF. And this was a pooled analysis of 12 randomized active trials. This is sort of meta-analysis, and basically looking at what are the factors that are associated with more than 10% weight gain. And if you look at it, the people who with a lower BMI and a younger age seem to have a higher weight gain. If you switch from tenofovir to TAF, then there's be a higher weight gain, and switch from efavirenz-based regimen, there's a higher weight gain. So you can see the pattern of things that are moving towards, and so what's important is that you need to practice when you go back to your clinic. That's what we are discussing now, so that you have to make sure that these things are disclosed to the patients so that they can make a meaningful discussion. And as I said in my previous talks, treating patients is a bidirectional interaction. No longer the doctors are there and the patients are here and we tell them what to do. That was about 100 years ago. No longer, so right now, we have to be at equal footing where they have the equal right to question and answer and get answers. So if we give all this data to them, they will make a pretty good decision as to what to take and what not to take. So then this is a HOPS cohort study. As you know, HOPS cohort was done by Hopkins and a group of people in Chicago, and about 10 sites. Basically, they followed from 2007 to 2018. This was a prospective cohort. Started in the 80s, but now this particular one is for just to look at the weight gain and medical records of people on integrases naive versus and HIV suppressed more than 1 year versus people who are not on integrase. It's actually a really interesting study. My next slide will show that. And the switched art, and then of course they were looked at the 6 months and after that. So my next slide shows what actually showed. It's a very interesting, if you look at it, switching from integrase-based regimen was actually more, if you switch from that to an integrase-based regimen, you can see that the weight gain is much higher. Then if you switch to an integrase plus TAF regimen, the weight gain is even higher. But if you just go on a non-integrase regimen, it stays stable, and the weight change was greatest among persons on TAF versus no TAF. And so this basically, it is validating what we have been talking about for the last 10 minutes. And the old age and the higher baseline BMI, but not sex or race, were associated with more rapid weight gain. Now, I'm not sure whether the last bit is actually true, because I think this max cohort may have not represented the true women and other ethnic minorities to make a good assumption, but I think there is a greater weight gain among the minorities and the women. So weight gain by sex and age and ethnicity, if you look at this very carefully, this is from Roger Berrimore from Texas, and he looked at different ethnic groups and looking at men and women, and you can see that the blue here is the blacks, the red is the Hispanics, and the white green is the non-Hispanic, and there is clearly a much weight gain on blacks than the Hispanics, but altogether there seems to be a higher weight gain among integrases compared to the other two. So now I think we can agree among us that integrase really is a drug that causes this. Now the advanced study was comparing dolutegravir with TAF or tenofovir or efavirenz. This was done in Zimbabwe and South Africa. Now, in those countries, the weight gain part could be a catch-up weight gain, so it's not like in the US or Latin America. And here you can see very clearly there's a difference between men and women. Women gain about 10 kgs compared to men 5 kg, and the distinction is quite obvious. Efavirenz has the lowest weight gain, and and the dolutegravir with TAF has the highest weight gain. So you see that although they are the best drugs, they're very potent, you can suppress the virus and a fairly good barrier to resistance. But if you're a woman, if you're asked, would you take it? Then you have to answer the question. So, and then you see if you look at the magnitude by the exact weight, among women, they put like 10 kilograms. That's about 20 pounds. That's some heavy weight, you know. So you realize that significant rate increases with dolutegravir versus efavirenz compared, and also with TAF versus tenofovir. And the plateau in weight gain after 48 weeks of in men, but not in women. So again, I am very concerned about women because I advise them when I put them on diet, on medicine, to take diet very seriously and calorie restrictions and getting them, not allowing them to go down the path of gaining weight. So estimated BMI increases were about 1.5 in males and 2 in females. BMI is a kind of softer way of telling about the weight. Kilograms are much higher. So again, looking at the multivariate analysis, it keeps coming back the same story. If you look at the graph on that corner, you can see comparing the different nucleosides, and you can see the TAF has the worst track record compared to AZT. Of course, AZT you're not going to use. On this side, against integrases versus PIs versus NNRTIs, NNRTIs seem to have a slight edge despite all the disadvantages of NNRTI and the caveats. But if you consider weight gain is an issue, or if you want to switch, if somebody is gaining weight, then this may be something that that's something you should be consider. So again, I'm going back to reiterating the point that TAF seems to be having the bigger effect than abacavir, and TAF against zidovudine, and the rest is given here. So doravirine, which is an NRTI, is actually could be a option in the presence of weight gain. I mean, mitigating weight gain. I'm not saying that, I'm not advocating any drug because my job is not to promote any drug at all, but make the patient decide what it is. But it is important that we as physicians give the data to the patients so that they can make a decision. You can't tell them because, you prefer one drug or the other. And the weight gain at 96 weeks was similar low with doravirine versus efavirenz. So doravirine has a comma similar to efavirenz. And the lipid profiles are similar. And the potential weight, the bone changes are of course similar. So this is a kind of a meta-analysis of all the doravirine-based studies. And you can see that if you compare with efavirenz or with darunavir, you can see that look at 96 weeks. Doravirine is almost like efavirenz. And this one, darunavir seems to do well. But in the other studies, darunavir has shown that that too increases the weight gain, but not as much as the integrase inhibitors. So, so the magnitude and determinants of weight gain with ART initiation in naive patients, integrase inhibitors is the worst. NRTIs, TAF is the worst. And then NNRTIs probably has edge on this. I'm not talking about which drug is better. I'm just talking about weight gain. I'm be very careful of what I say. And the cardiometabolic profile, and the underlying mechanisms, you could basically predict who is going to get worse and who is not. So these are some of the interventions you can do. So you can see these are simple stuff, but it's important that you prevent these things happening by explaining things well ahead. And we all know who have gained weight, that once you gain weight, it's very difficult to shed it, but it is better to avoid getting to that position by proactively doing exercise, proactively not eating too much carbs, proactively not eating fat. In fact, I tell my patients, a teaspoon of fat is much bigger than 3 spoons of sugar. So people think that, if I avoid sugar, it's okay, but it's much worse to eat fat. And I try to get people to not eat red meat. I mean, so I go through this whole things that I tell people how to avoid weight gain, and then, how to help yourself. Then, of course, there are new drugs, the anti-diabetic drugs that are used. Now, I started quite regularly using SGLT2 inhibitors because these are even for diabetics. I'm using these more than insulin because mechanistically they are more sort of safer, and also makes sense, because if you start insulin in diabetics, what happens that you give insulin, it takes the sugar out, and it pushes into the fat, and most of the people will gain weight. Whereas SGL2 inhibitors and GLP-1 inhibitors, agonists, creates a lot of weight loss, not a lot, but a fair amount. And here is a study which showed that GLP agonists, liraglutide, where you can drop about 10 pounds, I think it's 10 kilograms, 10%, sorry. So these drugs can be used, and they don't interact with most of the antiretrovirals, and so they are potentially drugs that can be used to mitigate weight gain if you have no other options of switching. Sometimes what happens that when the patients are on a drug for a long time, they are so reluctant to come out of the antiretrovirals because they are mortally scared that the virus will break through and there is virological failure. But although we all know that if switching does not lead to viral resistance. So finally, the take-home points is that the most individuals gain weight following ART initiation. TAF gain more than 10 off a year. And those integrators have the same problem. Other factors reflect trends in the general population are the social determinants of health. Now, this is actually very important, the social determinants of health. I don't know about Colombia. In the United States, the most of weight gain is among the Black and the Hispanics who are living in certain zip codes where they have food deserts, and people think that in the United States everybody is doing very well. They're not. There are a lot of people who have difficulty in accessing vegetables or fruits, or eating non-meat diets, not eating hamburgers, and because the street food and things like that are the cheapest. So the poor people eat those, and the weight gains. And it's consistent association between switching from tenofovir to TAF, and we already mentioned that. Base gain is associated with other metabolic issues and comorbidities. Monitoring this is necessary, and mechanism is unclear, but we all know that there is something really happening with these two drugs. And with that, I will stop. And I want to thank this Clinical Care Options. Some of the slides came from them, Turner Overton, from one of my colleagues, and the Practice Point, and my good friend Ernesto Martinez. And thank you, and I'll be happy to answer any questions.